Okay, we're recording. All right, everybody. Thanks for coming. Really excited to have Dan Rohde be here with us today to give us a little talk on the leadership in an HI revolution. Dan is currently the Vice President for Advocacy and Policy for the American Health Information Management Association. His responsibilities at AHIMA include overseeing the association's advocacy, policy, and influence activities and issues related to healthcare industry and the government, including standards. So Dan has the opportunity to work with stakeholders from really across the spectrum related to health information management, including Congress, consumers, other industry associations, and so on and so forth. With all of the changes happening in our industry right now, we're really lucky to have Dan here to talk to us about the work that he's doing and the work that AHIMA is doing, really on the profession's behalf. ICD-10 obviously is among the things that Dan has been tracking closely with his responsibilities, and I could only imagine the stories he has to tell us about the interactions with maybe other industry associations like the AMA and so on and so forth. But maybe we're not going to go there today. I'm not going to speculate. But Dan has a wealth of experience. He has experience in healthcare administration, HIM, consulting. And so we're really excited to have you here today, Dan. Dan comes to us. He has an MBA from the Carlson School of Management at the University of Minnesota. He has his undergraduate in business from Penn State University. And I'm not sure what that is all about. But really, Dan, welcome to the College of St. Scholastica, and please help me in welcoming Dan Rohde to our class. And this, you can just put it right here if you'd like.
Okay. I'll take the jacket off. What is this, anyways?
This is a wireless microphone.
Oh, okay.
It looks like a lighter, but it's a wireless mic.
If I say the wrong thing, poof, I disappear. Thank you, Ryan, and thank you for being here this morning. I'm pleased to be here. I was here officially about 10 years ago. I left 2 incomplete somewhere, and I came back to find them. And maybe someday I'll actually graduate. My job turned out to be a little different than I expected, and I just didn't finish the program, so to speak. But, and Ryan talked about ICD-10. We'll talk a little bit about ICD-10, but I want you to know that when Linda Kloss hired me in the year 2000, she put it on my goals statement of what I was to achieve in 2000. And 2001 and 2002, and it's still there. So I'm going to be very happy if we can ever get past that. What I thought we'd do this morning is I want to go over a little bit about this idea of a health information revolution, talk a little bit about where we are with the environment and a few other issues, and then just leave it open for questions on anything you want as long as it pertains to healthcare or health information. I'll take any kind of question you want. I may not answer all of them, but see if we can get rid of that. But I will cover those, and then we'll take it from there. I will give you one issue with me that you may notice on occasion. I have macular degeneration, which means occasionally I may go back to the screen and stare at it and try to figure out where I am, because sometimes the words just don't come up there. I've been looking, Ryan was very kind. I've been in healthcare for over 40 years. I know. But I've been looking at the kind of changes that we've experienced. Some people will tell you the changes happened since 1996. Others will say, no, it was the 90s. I'm not sure where it is, but what I do know is, like the Revolutionary War, I believe we're still in that change. And so we've got a significant amount of clinical changes that have occurred. We have great things happening all the time. Hopefully one of those will be macular degeneration. But as a country, we're way ahead in the research and the technology within the clinical sphere of healthcare. However, when we look at how it's applied, and we look at whether it's affecting healthcare as we know it on the population basis, you look at the statistics, and we're always down. We're always way down. It's a very disparate process. I used to say I'd only work in a teaching hospital because I knew that I'd have somebody there that would know how to take care of me. I obviously don't work in a teaching hospital anymore, but I sure want to be close to one. Just to have the kind of health care that I've gotten used to over the years, but that's not the case across most of our country. We've got a minimum experience with population health. I served on a committee about 9 years ago looking at bioterrorism and discovered that 10% of our public health departments, which are generally local, weren't even on the internet. So not only couldn't they send information out to WHO, but they couldn't receive information back. And while people think the CDC is this massive umbrella over our public health organizations, in fact, it has no public health authority. The states have the authority, and the states can relate to it and to the local communities any way they want. So it's not a very secure system. In Illinois, they're still using postcards to send the information in to the public health department to let them know what's happening. So by the time the public health department gets enough postcards to realize something's happening, it's happened. At least they don't have to go out on it. Our research data is in pockets. We have good research data, but we don't have the way to communicate on a large enough scale. And so what we're starting to see is our European counterparts, our Asian counterparts, are much more able to exchange information. And so this number one in clinical information is potentially soon going to be a problem. Okay, no problem. And some of the reasons I think most of you probably know in this class. We don't have common terminology yet. Our classification system is a little behind, as we've already mentioned, about at least 10 years if we want to compare it to the last major change in the country. We have a few countries that actually gave up on us. Taiwan finally decided to go out after ICD-10 instead of waiting for the U.S. to come up with CM. Israel is now trying to figure out when they should make their conversion, depending on when we make our conversion. We could have been leading the world in the area of documentation for procedures. The ICD-10 PCS was looked at by many countries back in the late 90s to pick it up and begin using in their countries, but they didn't want a terminology system that couldn't be guaranteed to be upgraded. And there was no guarantee it would be upgraded. On the other hand, the federal government's been upgrading ICD-10, CM, and PCS for several years. Okay, click on the bottom. Nope. You better come and do this. This is where my eyes give up. This is why I'm thankful to my wife for driving up this morning, or would be in real trouble. Would probably be up in the range by now. So our classification languages are metadata. We're starting to hear quite a bit about metadata. We're starting to realize that we need data to describe the data we're getting. If we're going to allow consumers to input their data into the electronic health record, we need some data to say this data came from the consumer, this data came from Dr. X, this data came from Dr. Y, Hospital Z, Lab ABC, but we don't have a common metadata dictionary in the U.S. And so we're just left without anything right now unless you're in a large system. So if you're Kaiser Permanente, especially in the West Coast, you've got a system that they've begun to develop. The Mayo Clinic has a vast amount of metadata. The Geisinger system in Pennsylvania, Intermountain Healthcare. If you notice and start watching those four, they also are beginning to work very closely with each other. And unfortunately are often the target of what we say healthcare should be because they're so far ahead, but they've been doing it for 15 years. So it's not like, oh, I'll just get the Kaiser system. It takes 15 years to get the Kaiser system. Geisinger will tell people that. So there's a big divide between this, and depending on where we go in our environment over the next few years, you may begin to see some very dominant healthcare providers that begin to stretch out. We already have Kaiser Permanente on the East Coast. It's not as good as the one on the West Coast, but we have it, and it won't take long for it to get developed even further. We now have patient-centered healthcare. This is an interesting revolution. If you want to talk to some older physicians, they will tell you this is a myth, and they hope it is. We are engaging consumers more and more on a daily basis to get involved with their health care, but we don't tell them how. The literacy rate is not exactly there quite yet, but more and more people are getting interested in their health care, and they want that communications, and they're looking for someone to help them communicate and get access to that system. And then we've got accountable care organizations. Now, why did I put that in the clinical side, since it's essentially a political piece? I put it there because what we're seeing now are organizations merging to form an ACO that have no other legal relationship. And what that means is the information being merged is coming from all sorts of disparate people. They don't have the same rules. So it's going to become very rapidly a place for HIM, because somebody's going to have to take the information coming from an array of physicians that may be Dan Rohde's physicians. I think I got 4 or 5. Going into Hospital X, and do I understand each of the record systems those 5 people have? Do I understand the vocabulary they're using, if they're using any? Are their records usually complete or not complete? And so now we're building a system to support clinical care, but the origin of the data is somewhat questionable. And so it becomes a real, I think it's going to become a significant issue. People are running after this because there's money in it, but I think it's going to be a while before we see the turbulence clear. And then we have the cost of health care, which has always been balanced against the clinical capabilities of the U.S. And so we enjoy being number one, but we don't necessarily want to pay for it. We know we're paying much more than any other country in the world and got less to show for it in many of the countries. So how does that fit into where we go forward clinically? And you'll see these all begin to merge. We have administrative simplification. Back in 1989, I got a call the 3rd week I was working for the Healthcare Financial Management Association from an insurance banker who wanted to know what would it take to send electronic checks for healthcare, which sounded really simple to them. They had just done this in the other insurance industries, the fire insurance and home insurance and auto insurance. How do we do it in healthcare? What data do we need? And the answer was, well, you need all the data that you got on the claim, and then you need all the data that you made yourself after you adjudicated the claim, and you need to send it all back because in our industry we might bill someone else for more coverage on the insurance. And they essentially went, you got to be kidding. 3 years later, we actually developed a standard for that, and were kicked out of the finance committee of the X12 because they said nobody in their right mind would send that much data. But we are an industry that has that much data. It may not be good data, but we have that. And so over a period of time, the Accredited Standards Committee X12 began to work on standardized ways of doing administrative functions, claims, eligibility, checking on the claims, paying the bill. I don't know if you've studied any of that or not. Good luck if you have. And we finished most of those standards about 1995. It took until 1996 to come up with Hipaa. And the reason that the healthcare organizations have Hipaa, the reason Hipaa exists today, is we are the only industry that couldn't come up with an industry council, a group of people selected in the industry to decide how to use the standard. We couldn't get one. The reason is we have over 900,000 providers in the country. We have several thousand health plans. We have exchanges. We have clearinghouses. Other industries have very little of that. The auto industry actually flew me over to Detroit to talk about that, and at the time, of course, the big three, Ford, Chrysler, and General Motors, were still the big three. They had a joint council, and they essentially told the vendors, you do it this way or we don't do business with you. And that's how they used their X12 standards. We couldn't do that in the United States. So the idea originally was, let's get the government to put together a council that can help decide how to use the standards. And in 1996, we got the law. Unfortunately, we didn't get the council. They picked on a council of academics, no offense to some of you in the room, and asked those people to oversee this process. There was no administrator type person on that council. But Hipaa did begin to provide us an idea that we would use standards. And we've gone on that since then. We've started it with electronic health records. We began to look at operating rules under Hipaa. So the operating rules for Hipaa, the how do you use this one way, the first operating rule will go into effect this January 1st. That's how long it has taken to go from that point to that point. And it took the Accountable Care Act, which still exists, at least up through the next election. That act provided for a way to actually talk about how do we use the standards. Right now there is one standard for a healthcare claim. There are 1,200 different ways to use that standard. So if you're in a facility, you can't just do it one way, and that becomes an issue as we begin to move. And then we look at improvements in Hipaa. The way the Hipaa law was written, you can only upgrade it after the standards organizations have upgraded it. You put it into the Federal Register for at least 2 months. You've analyzed all the responses, and then you put out a final rule, and then you have to wait so many months to do implementation. For the current transactions that are in place today, it took 8.5 years to make that change. That's comparable to my laptop, which gets upgraded by Windows, I swear to God, about every other day. And if you did it every other day, you don't even notice half the time, except when they screw up like they did about a month ago. But normally, you don't even recognize that change. So the idea is to get these administrative standards down to the point that they're updated on a regular basis, just like the software you use on anything else, and have that kind of an update happen. And we're headed that direction. The other part that then complicated things was privacy and security. Now, I don't want to make it sound like I don't believe in it, but the original rules said these data will be private. And now, if you've looked at the privacy and security rules, you know that thousands of pages later and many rules later, we added a privacy and security to this, which, if upgraded by the high-tech, will make some things very interesting. One of the high-tech rules essentially says that a patient can come in and tell you not to bill a claim for an encounter to their health plan, but I want you to bill all the following claims to my health care plan because I want them to be paid, but just not that one. So make sure that nobody in the record system screws that up. Yes? Oh, don't touch the screen. Oh God, I can't handle can't handle high tech at all.
I saw the first time.
Oh, okay. You know what generation I came. At the university, when we put in our first electronic record system, it was in the admissions office, and we kept typewriters under our desks for 2 years in case anything went wrong, because we didn't know about this. Anyway, so we've got these changes. We obviously have this upgraded in technology, and we're trying to now go through the regulatory process and clean it out and try to get it working in a smoother way, because it's going to have to be integrated into, and is rapidly being integrated into, the clinical, and I'll talk about that in a moment. If you looked at the meaningful use rules at all, the original meaningful use rule for the first stage actually took the administrative data and made it part of the clinical data. This is significant because in a lot of people's minds, and I'm going to say especially physician practices, the two are not the same. They've kept their data to get the bills out, and they got their other clinical data over there so they can get the patient healthy, presumably, and know everything about the patient, but they've never thought about it combined. Now we're talking about them combined. We're talking about the ability and the need to have the clinical data reflected in the billing data. Now, actually, that's always been a need, but it hasn't always been folded in that way, and we still do some strange things with our data because of old paper-based rules, but we're now rapidly changing that process so that our clinical data is effectively going to be the basis of all of our administrative data. And I can't wait for that to happen personally, having been involved with this stuff for so long, because it's always hard in any organization to go through an audit and try to reconcile the two when the systems just don't do that. And a lot of the systems still don't do that. A lot of the systems, especially on the physician practice side, are still based on an 8.5 by 12 or 11 sheet of paper and the amount of data that's on that paper. And since on the physician side you get paid for CPT, a lot of physicians will still say, I'll kind of hit the target somewhere near that with the ICD codes. That is going to change significantly, and I don't think most of the physicians have seen that happening. The technology side, you all probably know better than I, but again, we move very slowly. The Health Level 7 organization started in 1987. It started at the University of Pennsylvania, and I had the pleasure of interviewing there. They had 25 separate medical records in that institution. Each of the clinical specialties wanted their own. And so they were trying to come up with a way on how to get the systems to talk to each other. And Sam Schultz, who was the CIO at the time, decided to get some other informatics type people together and start trying to address how do I exchange information among systems within an organization. Now, any of you who've done any internships probably have not even faced this problem in many cases. Yes? 25 individual records. So if you were in the surgery department, you had a record. If you went over to internal medicine, you had a different record. If you went down to radiology and they were trying to figure out what to film and did you have any allergies to any of the substances they might use, you'd have to pull both records. And of course, at that point, it was done by hand. So what Sam was trying to do is merge that. And they've since done that and obviously went along with that. We're working with the International Organization of Standards. That sounds like something that we ought to be doing, but in most cases that is something that's only about 10 years old. And some institutions do use the ISO standards even in replacement of the Joint Commission with that. But what ISO does and what HL7 has done now in the last 5 to 6 years is it's brought in an international component. So now both of these organizations are international standards. We call them global standards because if I say international, it gets some people upset. It's we're selling out to other countries. But what it is doing for us is it's bringing in the experience other countries have had with the electronic health record, with ICD-10, and given a lot of good information into the standards process that we would not have gotten if it was strictly a U.S. kind of a component. So that's kind of where we've headed with that. We're working, of course, with the World Health Organization, HUFIC, the family of international classifications, and again, the industrial world's on ICD-10 plain with some variations among each country. We're still 9 going to 10, but we're already working on 11. And what 11 does is it merges this with the Sno-Med classifications down here with what I call ITSIDU, the International Health Technology Standards Development Organization, Terminology Standards Development Organization, which has now recently brought in LOINC. LOINC has 2 components. It's got an administrative component, which was proposed about 10 years ago to be a way of exchanging claims information, and it's got the laboratory component, which is now the major piece being used. And again, now that we have a law that says that consumers should be able to receive information directly from the laboratories, it means we're now bringing in consumer software, and not only our healthcare software that has to be interacting with this. So it gets a little interesting. And of course, we've got the standard electronic health record, which doesn't exist. I hope that's not a surprise to anybody. We have the HL7 version, which the government pushed with President Bush's proclamation in 2003, and Tommy Thompson starting his push in 2004. We have the standards. What we don't have is the use of the standards. It varies by vendor, and so we're not quite there yet with the standard electronic health record, but we talk about it constantly. And we talk about the ability to use it constantly. And one of the things that the meaningful use rule has brought is the idea of a certified standard criteria. And so as we see this certified criteria coming in place, we're moving a little closer toward that standard record. And then the mobile devices. And we've got two types of mobile devices. We've got the home monitoring devices, which now are part of our network of information that's flowing. So we're going to see Hipaa rules being devised to cover those pieces. And then we've got the BlackBerries and the iPhones and the iPads and all of that technology, which while you're all taught that nobody takes the record out of the institution, tell that to the physician that wants to take the iPad home that's got the information on it, or the BlackBerry, or any other information. And the interesting thing that I didn't realize until the annual convention this year, a lot of institutions are having a problem because, of course, the iPad is an Apple product. Most institutions are working on an IBM, Windows, Microsoft product, and most IT people haven't been trained to do the other one. So the ability to move the information from the iPad into the electronic system that the provider may have internally to the organization is becoming an issue. And how do you make that piece flow? So our progress sometimes brings us up to some interesting barriers and gives us an opportunity to find new ways of doing business. And I've already mentioned consumers, but one of the changes, in 2005, we were thinking personal health record. Actually, it was older than that. The idea of keeping a record of your care on paper even was certainly the first personal health record. And John Morgan, who was a informatics person from Intermountain Health, got on my back in 2002. I had cancer, and he wanted me to chart out my cancer on this thing. He thought this would be the greatest thing for physicians to use. So I had an Excel spreadsheet. That was my personal health record. In 2005, we thought they were going to be memory sticks, or they were going to be actually linked in. And I always tell the joke, I went and talked to our doctor one time, and I brought in a memory stick, and I said, gee, can I download my electronic health record? And he said, sure. There's a terminal, you can type it in. Because he had no means to move that data onto my little memory stick. And my memory stick came from a third party that we were using, and so the program in my memory stick didn't match what he had anyways. He's on his 4th EHR right now, so it's always fun to go in his office and try to do something like that. Now we're headed to patient portals. Doesn't mean we're getting rid of personal health records, but the patient portal is again coming to us from the meaningful use, and so we're looking at that integration. Again, if we don't have a standard electronic health record, how do you match the two together? And I'm very pleased to say that it was AHIMA that actually got the standard to allow connection to the electronic health records standard from HL7. It's a question of how do we get it into the products, and again, what's the vendor acceptance? The roles are changing. You're going to find that out probably more than anybody I know. My role certainly seems to have changed over the last few years on what I do, but we're looking at the clinician's role, and then we're looking at the value of education as we recognize that the clinician can't possibly do all this unless we could somehow implant something in their brain, and their brain would be hooked up to our electronic health record. So we're looking at changing roles throughout healthcare because of this information revolution. There are nurses who believe they should be health information managers, especially if they can get out of nursing. There are a vast number of allied health people who have no idea they should be getting involved with this. We've got roles changing because information technology is finally recognized as not the end-all, that you can't buy a Hewlett-Packard or a Dell, plug it in, and have an electronic health record. You might have the software, but how you use it falls down on you all in HIM, and to some extent with the informatics piece as well, as to how to develop it even further. But we've got this change that, believe me, one of the other things besides ICD-10 is get people to recognize what HIM is, what is it, and how does it work. And we're finally cracking that nut. We're finally looking at that. And the way we're looking at it is to talk about your clinical background, the background that does not exist with IT. And so how do you marry these two together? This becomes the new piece that we're using the term governance. How do we have an individual in an organization that knows where all the data is in the organization and how it should come together, and can work with IT, can work with finance, because we're merging the financial, the administrative together with the clinical, and develop a system so the organization has all the data it needs on the basis of having a data integrity backbone, I guess I would put it, within that organization itself. So that becomes a change, and we're looking at analytics. We're looking at certainly advanced informatics for health information managers, because as the technology advances, then you've got to advance. We're looking at clinical documentation integrity, which has been a bugger for the 40 years I've been in the business, of how do we come up with, we're having discussions right now with the Office of National Coordinator, how can we come up with technology to actually capture the information from an encounter or an admission? We haven't changed voice recognition in about 10 years. It gets a little better. It's not the dragon off the shelf you get down at the local store. You do have to have a better one than that. But how do you get that to understand dialects? Because people in Minnesota talk funny. And if you work in Virginia, nobody will understand you, but then if the Virginian came up here, you wouldn't understand them either. So how do we get it to understand dialects? How do we collect, if we're going to start collecting more clinical data, how do we collect that? And we've had a lot of innovation on how to get information out of the systems, contests from HHS and movies and films, but how do we get the technology there? We heard at the convention a number of organizations telling us about hiring scribes. And it seems rather ridiculous as we're moving through such a technology revolution that we're going to go back to hiring people to follow the doctor around and write it down or type it in or do something of that sort. So it becomes a new challenge that I think people are going to have to look at, and we're hoping that there'll be some money available, that's a big if, to get us on there. And then we've got the political. You're not as bad up here with your ads as we are at home, because we are a swing state. But nonetheless, I've heard some interesting ads since I've been here. We're very political in where we're headed in the U.S. on healthcare, and you've heard that in any of the presidential ads about this process. We've had an ongoing discussion for years. My second day in a hospital, I became a socialist. I wanted a single-payer, government-paid system because my first role was to work with the insurance industry and Medicaid, and it was a disaster because every rule was different. And over the course of time, we are merging some of these. And there were actually economists back around 2007, 2008. Uwe Reinhardt, if you've had to do any work with him, predicted that by 2012, everything would be one. He's a little off. I don't think we're going to make it in the next 2 months. But this discussion has been going on forever. When Hipaa came in, there was a real threat within the Congress saying, oh, we're going down the road to a single-payer system. And that discussion kind of changed. But then we got to quality measurement, and people began to realize that if we were going to change the healthcare system, we've got to be able to pay on something other than the dollars and cents associated with claims. And so the quality revolution very quietly has come in over the last 10 years to the point where we have a commitment by most payers to go to a quality-based system. It's just we don't know when we can go because we got so much else going on as the evolution has changed. We've taken the clinical with the AHIMA in 2009 and begun to build reporting for quality measures, even if we can't agree what the quality measure ought to be in the first place and what makes up a good quality measure, which is partly our role in talking about how to get the data and the physician's role, the researcher's role of saying what's good quality. But we're getting this push anyways, and you'll hear a lot more about that, I think, over the next couple of years as the quality people try to push a system that doesn't necessarily get supported by the technical system that we're coming out with right now. And so we've got that process, which then built into the incentive program that we call Meaningful Use. We've got payment changes already happening with pilots. I talked about ACOs, bundling, idea of taking the physician's charges, maybe they're the physicians related to the hospital, and the hospital's charges and paying one flat amount. It's being worked at already in Geisinger in central Pennsylvania very successfully. Question is, will the physicians be willing to work with the hospital, again, combine their information to be able to do that? And will they be able to do that before they are required to do it? So we've got this reimbursement process and coverage, and then we've got the election. The election will impact this significantly. If the Republicans were to take the House and the Senate and the presidency, the timeline on this will be disrupted. I'm not going to say the progress will be disrupted because I think we're headed this way anyways. The insurance companies finally came on board to realize that having the information gives them a better way of providing a product. Now, you may argue what they cover and how much profit they make, but it's giving them a means to finally target this to what's the actual health care. And so you could take this from the standpoint of data to come up with better coverage, and if you're sicker, you should pay more and less, or you could take it from the other end of the spectrum and say, oh, we want to combine everybody, have an insurance program that covers everyone to a certain extent. Some people often say the same amount of insurance as Congress gets, and go from there. But that's one of the things we're going to look at. It will not happen overnight. The 21st of January, you're not going to see the demise of all of this. But if you were to have a significant Republican takeover of the government on this election cycle, that's certainly the direction they've signaled that they want to go. And so you will see that disruption. If the Democrats, I'm going to say at this point, hang on, keep the Senate, keep the presidency, then we're going to have this bumpy ride forward toward this process probably a little quicker. And that's the process you're going to be working with over the next few years. And hopefully I'll be on Medicare and hoping you're doing your best to keep me healthy. So I put this slide in before the weekend. We're from Virginia, but this is essentially where the healthcare industry is right now in trying to make changes down to the individual practitioner who has to face this, and if they're a physician, also has to face the fact that the Medicare reimbursement system right now doesn't pay what the physician needs to keep going. And some might say the hospitals are going to be soon in the same position. I don't know if that's true or not. But we have these rules with these due dates. We had a very stormy changeover to the upgrades in the Hipaa standards. We've got ICD-10 now at 2014. We've got our high-tech, I've got up to 2015 plus. The plus is that the idea behind this is to keep going, to keep programs going so everybody eventually gets to the standard EHR even after the incentive money goes away. And so there is plans being made for MU 4, 5, 6 in the government circles. We've got other programs coming in on the beginning of January of this year, and this is where I have to do my stare. The Meaningful Use 2 comes in January of 2014. Interesting process. It allows for the reporting of quality data in ICD-10 10 months before ICD-10 is required. So organizations that are ahead of the game can report their quality standards in ICD-10 if they so desire. And of course, hospitals are on the cycle of fiscal years, so everything for them starts October 1st. Physicians start January 1st. So it's going to be interesting to see if some organizations begin to push on that process as well. The other thing in Meaningful Use 2 is the advent of Sno-Med as a voluntary terminology, but one that has to be there. And when I was talking about roles before, Sno-Med is probably one of the biggest things staring us in the face right now, because in the U.S. we have very few people that understand Sno-Med, let alone understand how to use it. It's a computer-based terminology. It's not one you open a book and you pick a Sno-Med terminology, and a lot of people think that's what it is. It's just another classification system. It is a computer-based language that is going to be embedded into the electronic health record, and we need people that can understand that and use it, as well as map it both to the computer code and other codes like ICD-10, ICD-11. So that's coming at us. The Accountable Care Act, most of the pieces of the Accountable Care Act, unless the election changes it, we've got a 2016, few remnants left in 2017. And then, of course, we have the Medicare, Medicaid changes that we have every year around. So this is the place where the physician is right now. And if you saw the movie, you know the boat didn't make it. All right, so let me just talk, and I've kind of done some of that already. Some of the other changes we're facing right now, if you've been following the press, is fraud. Can we be fraudulent using electronic health records? We've said, you know, it all depends on how you do it, but we're looking at that right now. The New York Times did a program on hospital E&M coding, and they put it as the responsibility of electronic health records. Actually, that's wrong. E&M coding is established through a policy of Medicare and Medicaid. It's ridiculous. And in the hospitals, it's even more ridiculous because it allows each hospital to set their own standards for E&M codes. And we presented a way to do that better in 2003, but they've been ignoring it. Maybe they won't ignore it anymore. Coding creep comes up every year, which is a good excuse on pulling payment back from facilities, but essentially what it means is as we get better codes and coding, the process of it, we're coming up with information that essentially says the patient's sicker, because sicker patients is what's happening in the healthcare industry right now, which then requires additional payment. Well, if you don't want to pay more because it's a budget neutral system under Medicare and Medicaid, you call it coding creep and then you lower it by some percentage. That's my simple explanation. Madonna can give you the technical explanation afterward. We've got the incentives for the EHR adoption that are coming through. In 2015-16, we begin to get the penalties. So if you don't convert to and meet the meaningful use criteria, then you begin to become penalized. And that could cost anywhere from 1% to 5% over the ensuing years. And it's not as early for the Medicaids as it is for the Medicares. Physician payment reform has been on the docket with Congress since 1991. 1991 is when it went in. It went in mainly because of the first Iraq War. Congress was prepared to vote it down. The Iraq War happened, and Congress decided to adjourn and support the president, and the AMA has been trying to change it ever since. So it has been on the docket now for almost 20 years, I guess actually 20 years, and it is a disastrous process which impacts the physician's view of health records. Because if you're not getting paid enough to give the care to people, where do you come up with the money? Incentives are good, but the incentive money comes after you make the investment. So where does the investment kind of through. Congress has looked for the last 2 years at an investment credit. We give you the money, you put it in, you get your reimbursement out of meaningful use, and you give it back to us. So it's a circular system there, but that has yet to pass. So we've got that kind of a process. We've got the deadlines I mentioned, and we've got a question of what is our goal in this process. What are we trying to change? And how do we change it from a standpoint of an industry that is very strong, largest economy in the country, 1/6 of the economy, health plans making decisions more or less independently, the federal government, which pays almost 60% of the money going into many of the health programs. Are we all moving in the same direction? Is HHS itself moving in the same direction, which is often a problem? And then if we are, and we can figure that out, then can we get the vendors to do this? I'm always asked by members, how can we force the vendors to do the product? And I always say back to them, well, ask them for it. Well, one entity alone can't always ask for it. There's a big company east of here, in the next state, has a large organization. Thank God they finally hired some HIM people last spring. They should have done that years ago. But they're so big that it takes the union of almost all their customers to get a change made. And so that becomes a problem. So we've got two ways to be involved. We either get more HIM people into the standards process, so as the standards come forward, they match what we believe is appropriate in HIM, but we also get those people taking a leadership role in their own organization to demand that of their vendor. And when I talk about leadership, as I will, the biggest problem is getting HIM people within their organization to exert that leadership and make sure it's not just a technology decision when it's purchased. It has to be a technology decision that meets the basic HIM principles. And I may be able to skip some slides because I kind of went over that already. Fort Necessity is a fort near where I lived in Pittsburgh, Pennsylvania, that was built by Lieutenant Washington. I can't even remember what his rank was anymore. After the French Indians pretty much decimated the British. They buried General Braddock and ran their wagons over his grave so that the Indians wouldn't scalp him. And they hurried and put the fort together, and they were able to hold out long enough for Washington to work out a compromise with the French and pull all the soldiers out and walk merrily home. If they did that today, there'd be 20 inches of snow. But essentially, it took a leader to think about what I give up, what do I take, how do I make this change happen, and he got them out of it in essentially 3 days. And the fort is nothing. It's a bunch of logs on end with spikes in them. That was the entire fort, and I don't know why they just didn't push it in on them, but I guess they weren't able to do that. But what I was trying to get to is understanding these issues. We have a significant problem in healthcare that most people don't understand what's going on, and we've got so many people that have to understand it and understand the issue of health data and information and integrity. This has been a battle for a number of years. Oh, let's change the code because we'll get paid more, which would fit the fraud definition. We don't need an ICD-10 code. Why would you need that additional detail to tell you? Why do we need more than 4 codes to tell us about cardiovascular health care? I'm a non-Hodgkin's lymphoma survivor. There are internationally 32 codes for non-Hodgkin's lymphoma to talk about the origin and give in-depth information. In the U.S., we have 2. So why do we need those? Do I really need the 2? What's the purpose of it? We don't have a common understanding of that right now, and we're often at the front of that trying to come up with it. How do we collect the data? And what's its effect on the primary and secondary uses of healthcare? I have one of the first medical home physicians in the country. And if you get sent to a specialist, he's been doing this manually, phone and paper, and you don't get a report back to him from the specialty within 2 days. He's on the phone, bugging the heck out of the doctor. And so when I tell them who my primary is, I occasionally get interesting comments. But he does get the report. So how do we do that now? How do we look at the needs for all of these pieces to work together? There's still this assumption that technology can install it itself. And I am one of those victims of that piece because nothing I've ever installed has worked the way I have it. And the help button doesn't always work, and I like a manual. But we're now working with the idea, and in Congress especially, that you just plug in a box and it works. And some administrators are like that as well, because the IT guy sold them on that along with the vendor. So it's an area that we've got to step into. The vendors will provide what the customer wants. The problem is a lot of the customers, especially physicians, presume the vendor knows what they need. They assume that every vendor, and especially the small vendors that treat the physician community, read the Federal Register and understand all the rules, and they built it into the system. And essentially, it's not there. And so there's this weird system here of trust. And one of the things coming out of meaningful use, maybe that will help some of that, is this idea of certifying the software to meet certain needs. And we've had that discussion a lot lately of could we build all the requirements into certification so the vendors would have to guarantee it's there. Because if it's not there, most physicians haven't been trained to build it into the system themselves. And unless you're going to a large clinic, you don't even have an IT person in many organizations. And I've argued for a number of years that some of our HIM folks ought to start a business of going into a group of physicians once a week. Each day you have a different group, and serving as their HIM expertise, because that's a need in our physician practices that can't necessarily afford somebody on a full-time basis. But I think there's a lot of money to be made there. And so the capabilities and the technology is all tied up, but it's all tied up in questions. And we aren't necessarily getting the information back. The revolution that I keep talking about in a value sense of what's the value of this. The physicians will tell you because of their payment, lousy payments for Medicare, what value do they get out of the system? They haven't looked at the system enough to say, again, I'll pick on our doc, he's 2 physicians, 6 nurse specialists. If I could take even the ICD-10 codes out of the system and begin to profile them against the ages of the patients, I might begin to see how I treated this patient across my 8 people. And if I began to see that and I could begin to look at what worked best within even my small practice, I might be able to do healthcare better. And of course, if I can expand that into population health, I've expanded that information even further. But as I said up front, we don't even have a marriage between public health in our physician community and even our hospital community often. So our ability to learn from the data is one that we still need to explain to a lot of people. Here's the possibilities of what you can do. And that becomes a significant use of how do we use the data. What do we do for comparison? A lot of physicians don't realize, and I don't know, I haven't been back to Minnesota for 2 years, but certainly on a federal basis and several states now do comparative rankings based on the quality indicators. HCAP, yes. So we're now having consumer sites that allow them to be comparing physicians, hospitals, nursing homes, from a consumer perspective, which means no training at all, because we don't train in any of this in our high schools about health care, making comparisons and deciding who to go to. When we moved to Washington, D.C., I went through the book of my HMO at the time, and I looked mainly for English-speaking physicians who had a board certification. That was my criteria at the time. It was the only data that was available. Now we've got people making decisions on this quality data, but if the physician doesn't understand that that data that they're sending out now is being used for a quality review, then we've got significant problems. And I asked about Minnesota because I still have a brochure in my desk from the 80s when we did a study of 12 hospitals in Minneapolis, and my hospital came in last because we were the tertiary care hospital. We were getting the patients from the other hospital when they were too sick, but that data wasn't collected at the time. It was only the primary diagnosis. So understanding the data and how it's going to be used becomes a significant role that, quite frankly, we still have a lot of work to do, and almost has to be individual, down to the employer size. And so it's understanding that it's getting employers to understand it well, because employers are going to start using the same data to decide who should be in the network. We're almost back to some of those issues. We've got to have a sense of, can I trust the information? And I can tell you information I trust and not trust, but we're not there yet to say, is this information valid? A number of insurance companies started having personal health records, but the information came from the 9 ICD codes for diagnosis and the 6 codes for procedures. If you're a chronic patient, that's not enough data. And that data may be wrong because it's so vague. Hopefully it's right because it got the claim paid and it's not fraudulent, but it's still too vague of a data to work with. So we're looking at that kind of a change of needing to get the data integrity raised so people trust the data. Otherwise, we go into audits. And right now, we've got audits in the healthcare industry. One of the jobs you may want to do someday is be an auditor, because, boy, we're auditing for RACs, we're auditing for quality, we're auditing for third parties, we're auditing for a number of different things. So we need to look at that kind of a process. And I'm going to flip through these. I know that you're going to share this, so I'm going to leave these because I'd rather get into questions, and we're getting to that point in time. I just wanted to mention AHIMA. AHIMA just had a strategy session, and these are the main areas that we're going to be looking at in 2013 and beyond. The issue of innovation, as I've already talked about, how do we use technology better in what we do? Informatics, in how do we apply it? We often call ourselves the applied informatics people. It's great to have all the information, but how can I really use it? The data in informatics also from a standpoint of getting people to understand how to use the data. That we actually have information we're just wasting. It's sitting in the records, but we're not using it. The public good, and I'm missing one here, leadership, which I think becomes your role, because, quite frankly, if we don't begin to become leaders within our own organization, then we can't meet this other piece. And then the one that isn't on here, and I don't know why it's not, it should have been here, is governance. We believe that health information managers ought to be the governors of the data in their organization. It's changing. Some of it's going from paper to electronic. It's all over. People don't realize it. It's in practically every department within the organization, but somebody's got to pull it together and know if it's the same information. You could have different information on the same patient, so how do you put it together? We've got all of that has to be accomplished, and that's where the AHIMA agenda is going. These are just some resources, and like I said, questions on anything? Go ahead.
I jotted down when you first talked about the standard EHRs, there's no such thing, and the fact that we're supposed to be implementing electronic records. That, I don't know how to ask it, but it's the implementation of electronic health records, but does that include like the standard across a standard EHR? Does that make sense?
So you may have no EHR right now, or you may have one. We call it a legacy system. And along comes the meaningful use. And meaningful use as the criteria, standards criteria, in other words, what standards must be in a product in order to qualify as a meaningful user, begins to take parts of that HL7 standard and some of the other standards out of ISO and certainly of the terminology and classification centers. And it says in our criteria, these are the standards you must use if we're going to pay you as a meaningful user. And so it's picking these standards up. They're put out for comment, they're finalized. The next go-around, you have to have your product, the computer you're using, either has to have a module that'll meet those standards that are now being developed, or you don't get paid. So the idea is, as we move along from stage 1 to stage 2 to stage 3, we'll begin to pull more of these standards into place. It's the U.S. way of doing it. We don't want to mandate that everybody has to have a standard EHR. The presumption is that the vendor, by wanting to have these in their products so their customers can get this inurement money, will have them in the system for all their customers. So even their customers who are not meaningful users could have access to this. And one of the issues, and I only hit it gently here, is we're finally beginning to realize, thank God, that there's a continuity care issue. And the problem with meaningful use is that it only applies right now to physicians, certain physicians, most of them, and hospitals. It doesn't apply to home health, long-term care, rehab, behavioral health. They're all out of the system. There's some senators trying to change that, but right now they're all out of the system. So eventually the idea is to bring those people in, and again, indirectly force healthcare providers in the U.S. to use these standards.
Because I mean, you hear so much about standards, but...
Yeah, we use the word standard for all sorts of things.
But it's what really goes under this.
And it would be bringing the standards in. AHIMA is the secretariat for the ISO healthcare standards. That means we run the office, coordinate the meetings, that people come together and put the standards together. We've been working with the Office of National Coordinator, which is one of the great things I think that came out of the high-tech process, to try to get a body that would harmonize the standards. In other words, how do I bring the standards together and make them work with each other? And as we, the other things high-tech did, as I've already mentioned, is it's brought the consumer in. So the consumer now has to have access to the system, so we have to start thinking about their technology and the standards they're using. We've got certain documents that have to be produced electronically, and some of those documents certainly could be used to move the information from the acute care facility to the post-acute long-term care facility, so they begin to pick up some of the standards. We've been very helpful in getting a number of the long-term care people into the HL7 group. So we're looking at, the neat thing about HL7 and the other standards groups is their standards have to interact with each other. So if I have a healthcare standard for hospitals, electronic health record, and I then develop one for behavioral health that may be a little a variation of the same thing, but it handles the behavioral health problems, those two have to be able to interact. So if I can bring those pieces in at one at a time, eventually I get there. The only problem with this system is it could be another 20 years till we get to that process, unless the demand increases. And so as we get into, this is why I love my job some days, as we get into something like the ACO rules, and so now I'm going to pay you to act as a network for healthcare. Well, you almost are forced to come in and begin to use standards or software that will allow you to communicate with all the people in your accountable care organization. And so if I've got those people working and I begin to bring in these processes, maybe I'll speed the process up a little bit. And so we're working on a number of things that are happening at the same time. We're trying to speed up the adoption. We're trying to change the reimbursement system because it is such a big factor in the U.S. I mean, the only thing that kept us from going to ICD-10 early on was actually the health plans that didn't want to move. We could have been on ICD-10 in 1998, saved a heck of a lot of money because most people weren't in electronic health records at that point in time, and have none of the problems we have with the implementation now. But at that point in time, the insurance companies didn't want to change their legacy systems. And they were forceful enough, they're big, to stop it. And the physicians were right behind them on that basis as well. But it's a combination of us pushing as purchasers, but it's also a combination of then getting our government to loosen the standards up, because as we've built some of these laws, we've actually created our own barriers. Does that make sense? Sure. Congress wants to know that as well. Now, with the recent stories about fraud, one of the questions essentially you're asking is, are we auditing the process to make sure it's in the criteria, and how do we make sure it's actually being used? And that's a big gap right now in the system. There was a proposal at one time that perhaps a body like the Joint Commission should go into an organization and see if they're using it right. Of course, nobody could figure out what the definition is of using it right, because we really haven't gotten that far. That's why we see the value of HIM, being able to go into a physician's office and show them how to incorporate what they do into the technology that they have, or hopefully maybe even better, getting with them ahead of time to determine what the technology is that they need in the first place, so it actually integrates. I mentioned our doc's on his fourth record system. Essentially, it was because he had nobody to tell him how to use the system. And there's actually, on his third system, he actually had a pharmacy company offered to bring a nurse into his office and teach them how to use the system if they could take the information out of the system for some of their research. And I did read his privacy policy, and it was appropriate, but I was a little upset about it myself, but that was the only way he could get that technology, which is why I say I'm expecting some people to begin creating businesses that would go into these places. One of the issues I'm working on right now is working with the health clinics out of HRSA, which are mainly the storefront type clinics. There's about 1,200 in the country, to see if we can get HIM students to go in as interns in those companies or in those clinics to show them, because they got tons of money, but nobody has ever sent anybody in to teach them how to use it. It's kind of like back in the before your parents were born. I had an uncle that was a city planner in Alabama, and they had to show people how to use toilets, because the people that they built these facilities for had never used a toilet, had no idea what they were for. Well, a little more modern than that is, how do we use this? How do we update? How do we get the technology updated? And quite frankly, you're probably the answer. As I look around the room, you have more technical knowledge of computers and peripheral equipment and all of this than I certainly do, and probably a few other people in this room, because you've worked with it all your life. You've been born into it. And this is where I see the leadership coming from the graduates of this program and others over the next couple of years, is actually to go in and show people how to use the technology they have, because often they're too busy to do it. The record room is still in existence. They haven't quite gotten to electronics, but they've got such a demand on what they have to do that I'll get back to it. I'll do that. It's kind of like I have a piece of software at home I've had for almost a year that I haven't put into my computer because I haven't had time yet to do it and play with it. But they need someone who can automatically pick that up. There's other changes. When I was putting this together, it was like where to stop. As we open up patient access, for instance, and under the high tech, the patient can come in meaningful use too and say, I want you to send my record to such and such. And you have to send the electronic record at least to such and such. Well, that changes the whole release of information process from what we've known in the past.
So I was actually just going to ask that. Where does an ROI come into this? I wasn't sure if I was confused with a personal health record with your information or your hospital record. Because we were saying this, and the hospital had an internship this summer, and so the biggest thing I learned about was ROIs. And for every little thing, like you need a release of information, you need to see this first, they need to come in. So that's why this is off of my mind.
I live with an ROI person who's let me know how many she's sent back and let the attorney figure out how to do it. But the change is, and we've talked about this in the office, of first of all, the ROI is probably going to depend more on your state law than your federal law. And if the consumer patient comes to you and is legitimately the consumer or the caregiver or the designated party, whichever piece of the different rules you have to use, and they give you a fob and say, put the electronic health record information on here, you have to do it, or you're going to be in violation of either meaningful use if you're a meaningful user, but probably of Hipaa when those rules are updated within the next year as well. And it's not up to you, unfortunately, to determine where they're going to take that information or what they're going to do with it. They may be suing the heck out of you in a malpractice case. Well, yeah, you have an authentication issue.
And that would be filed in the
Yeah.
court. If you want to know who you're...
See, this is where I learn everything at home.
Like, so the ROI process wouldn't be completely done away with?
No, it's not done away with.
Okay.
And in fact, the biggest problem we have with electronic health records is we really haven't done a good job yet of figuring out how to authenticate the various pieces going into that. How do I authenticate my system to make sure that the information going into my record is coming from reputable people? How do I know that it really is the patient's information that I'm getting? How do I know that it is information from another facility? And I still have the obligation of release of that information. So how do I authenticate where it's going other than the consumer when a clinician says, I want to send the information out for this, that, or the other? We've got all those authentication issues, probably worse than we've ever had them because we paid the least amount of attention to authentication because it's so icky. We have consent forms. The consent form, we've got 50 states trying to come up with a consent form. Well, in Duluth, you might get a patient from Wisconsin. So how do we deal with that? When I worked at the U, we literally dealt with about 40 states. I fortunately didn't have to deal with 40 at the time, but the question now is how do we get our authorizations and our consents standardized, which means convincing 50 legislatures to give up something to make that work. So while we're maybe making a few things easier on ROI, we used to have, if you were giving the information to an attorney, you could charge more in some states than if you gave it to the patient. Well, now we don't go through that process, but how do we work with it? Follow-up questions.
I just find it funny because I read all this stuff, and now I'm sitting here like, oh my gosh, what did I get myself into? But when I was interning in a physician, I was walking with someone, and a physician was walking, and I said, "Hi, doctor." And oh, I'm interning in the HIM department, and Kentucky feels my forehead.
Well,
there's a lot of stuff like
this is actually, if you can keep an eye on what's happening, this is where you've got, this is key. You are essentially in a profession or about to enter a profession that is smack dab in the middle. You're in that boat too. The difference is you've got to read on that, and you've got the ability to make some changes in what you know. And that makes all the difference in the world, is to be able to see that, because people aren't seeing that. And that's causing serious problems. But if any other message I can get through today, it's taking the knowledge, keeping up with the practice, and then making sure that within the organization you find yourself in, that you could actually go to somebody and explain it to them. Whether it's that consumer who might want to give the information away and you have to at least explain to them what the privacy implications might be, or it's the organization that's building a system that makes it impossible to follow some of the rules because of the way the system's being built and the vendor doesn't care. The one I told you about, the patient that can stop their information from going to their third party, I haven't figured that one out yet. I'm hoping one of you guys will. How do I encapsulate the information and yet not, if I'm in the follow-up visit and the follow-up visit uses the information from the previous visit, how can I send a claim and not have the information in it? How do I build a system in my organization that does not, that anybody that gets a call can see that amount of data, that little piece of the 10 years this patient's been there, cannot be released? And quite frankly, if I was in IT, and I'm glad I'm not, I was at once, I'd say, well, why would you do that? Well, I'm doing it because the U.S. Congress passed a law and said that because Dan Rody didn't do his job in Washington to convince consumer groups that they don't want to do that, which is probably true. So this is the opportunity. Not an easy one. I've had interns here now for, I think, the last 4 years, and just I love it when they can come in town when we're having some of these meetings and listen to the advisory committees try to figure this out. And typically there's no HIMer in the advisory committee, so you sit on your hands and you want to scream. And then you wait till they say open mic, and then you go up and you say, you guys need to do this, do that. Oh, sometimes they still don't know, but that's our role, is to try to make some sense of that. That's a role this year as we are forming our practice councils. Our student advisory board has asked if students could start coming on our practice councils because they're dealing with some of these issues for us. We're looking to the field to say, how did you solve that problem? And we do that because California has much stricter ROI rules and regulations than any other state that I know of. We can go and figure out how they did it. We might be able to give the information to you. And other states are the other way around. So it's a communal kind of a process. But no, I don't think it's oh my God, what have I gotten myself into? I said that the second day I moved to Minnesota in December. But it's how can I take advantage of this change to do it? If you're going into HIM thinking you're going to be an advanced clerk working with paper records in a record office, you have picked the wrong occupation to think that you've got an easy job now and you'll just spend your time in that. This is an extremely dynamic job that you're going into, and if you don't run with it, if you run with it, it's going to be great, I think. I really honestly believe that. But going from there, I think it really becomes an issue of how you deal with it. Other questions?
Well, I agree. I think, these guys they're up to really exciting stuff that we've been working for a long time. When I was at school 30 years ago, we were doing the ICD-10, so it was really not a why I was reading that.
Yeah.
Well, we were against it. Now I'm determined to stay until that's in place.
She waited for ICD-10. Rest in peace.
But there's so many exciting things happening. There is not an answer.
Other questions? Thank you. I hope this helps. I hope I didn't discourage anybody.
No.
Thank you.